Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good afternoon, everybody. Before I start, actually, I thank my colleagues, Sister Rina and Sister Safiya, for inviting me to participate in this workshop. For the last 2 days, Professor David Hayes, actually, he presented to us two outstanding topics related to pacemaker. He spoke about the ECG of the pacemaker, and as well he spoke about the clinical and indication of the pacemaker implantation. What I'm going to share today to you, I'm going to talk about some troubleshootings of ICD and pacemaker, and after that we may continue. Thank you. So what is the objectives actually for these presentations? To describe an approach to interpretations of device tracing. Give example of unknown device tracing, because you see in the critical care units, most of the time we may face actually this kind of the patients whom they do have pacemaker implantations. So usually they call us. So the nursing over there, she should know at least the basic, some troubleshooting of the pacemaker. To suggest possible solution to correcting unwanted behaviors if found in a device system. So what is a step? Because you see, for any situation, for corrections, we should have a methodology. So how we can solve the problems, and how we can diagnose the problems, and how we can manage to solve the problems. So the first things, we should define the problem. Second thing, the history is very important. So for the pacemaker, the history is essential actually. And you see the history, it is individualized. It is not the certain. Many times from my experience, I've been called to the units over there because the pacemaker post-implantations not working. So the people easily, they can go to the conclusions. So our advice, usually for our colleagues, they're supposed to look for the other alternative leads or to call for 12 ECG leads. This is one thing. Second thing, they should look to the underlying rhythms of the pacemaker. So say, for example, this patient is a complete heart block. So I look in the chart of the patient, I see what is underlying rhythm. Is a complete heart block. The rate was 40, 50, 60. This is very important to me. So what is the diagnosis? Why this implantation occur from the beginning? Is the patient complete heart block as such, sick sinus syndrome, sinus node dysfunctions? All this is in interpretation is completely different. I will give example, patient with a complete heart block. If the heart rate over there, the 40, and the people over there, the nurse, she called me and they said, okay, the pacemaker did not work. So I will just go over there and see the ECG. If the spike of the pacing wandering every place, that means, and the heart rate is a low, like 40. So this definitely, there is a miscapture. That definitely is there is a problem. But if the patients, in reality, with a sick sinus syndrome, okay, and besides that, the rate over there like 70, and no spike of the ECGs, so this can be a normal phenomenon. Because first of all, you're supposed to think of the mode of the pacemaker. Is it a DDD or is it VVI? If it is a DDD, it has a timings. It has a 4 times. It's sensing the atrium, sensing the ventricle, sensing atrium, pacing ventricle, pacing atrium, sensing ventricle. So you should be aware about that before you come to the conclusions of the pacemaker is not function. And after that, we do usually or routinely, we retrieve the informations by our programmer. We retrieve the information and the data from the pacemaker to the programmer. And that one, we can also analyze what is going on over there. Remote monitoring Nowadays, in some companies, actually, they do have these facilities. Actually, usually it gives the physician a hint about the problems because this is connected to the network. So it can give the early indication what's the problem. Is it a lead problems, or it is a device problems, or it is instability in the patient hemodynamically. Step number 2, list the potential causes. So what is the causes? Why these problems occur from the beginning? Is it a lead issue? Because you see from many studies show that in the pacemaker, usually the problems are triangles. Either lead problems, or either device problems, or others which related to the patient himself. So lead problems, the majority of the problems of the pacemaker, not usually, but more than 55% to 60% from the leads. So what's the problem with the lead? Is it a lead early problems or a late problems? Early problems usually happens after the implantations. So the lead may dislodged. So the dislodgement, it can be assessed under radiographic views. We have two kinds of the dislodgement. We have a micro dislodgement and we have a macro dislodgement. Macro dislodgement easily can be detected in the X-ray, but micro cannot be detected. So this is one of the first problems can be occur or reason is a lead problem. Device issues. Device, usually it is a late because due to the depletions of the device itself, the battery, because the pacemaker is a battery. So device problems usually due to the depletions. Other issue, medications. So all of you working in the critical areas of the cardiology, problems of the medications. Amiodarone, cetalol, flecainide, all this increasing the threshold. Besides that, some medication can reduce the threshold like isoprel, atropine, epinephrine. So you should be working over there and look also for the electrolyte imbalance. Patient, is he hyperkalemia, hypokalemia? So be aware about this. So it is very important before you go to the conclusions the pacemaker does not work. Step number 3 determines the causes. Diagnostic testing and analyzing. So, and after that, we come to correct the problems. Corrections of the problems can be non-invasive by programming, or can be non-invasive or invasive by implantations or adjusting the lead. Maybe the lead dislodged, it needs to be adjusted by physician, or maybe installations, maybe at the header of the lead is not working properly. This can be invasive, as I mentioned. So I will go on to give some example of some cases, and I will see the solution as well for these cases. So this is a history of these patients. An active, energetic 80-year-old woman was admitted to telemetry unit for evaluation of a cardiac symptom, including chest pain, pre-syncope on exertion, and slight congestive heart failure. This patient had a unipolar VVI pacemaker. During hospitalization, the ECG in the figure 1 was recorded. So history is important. Here are the 3 issues of the history. You can see it here properly. Chest pain, pre-syncope on exertions, and besides that, congestive heart failure. So these 3 elements is very important to detect to you blindly this patient maybe has a pacemaker syndrome. Besides that, this patient is a VVI unipolar. This is the figure, actually. If you look to the figure wisely over there, you see the spike here. This is a spike. That means you see the spike, and after that, you can see the depolarization and contractions of the ventricle. But we do have a pause here. So the cycle lengths between here and here and here, they are equals. Actually, like 70 beats per minute or like 850 milliseconds. But we do have a pause. And after that, we do have. But the spike is everywhere here, so spike is not wandering. So what is the cause of this pause? Okay, so we try to see the stepwise how we can diagnose this and how we can solve the problem here. So